This is Ginger Bandeen from Pinnacle Health Informatics. So this week, our webinar, I'm going to be presenting some information that I shared at the Harris Conference, which was a couple weeks ago, maybe 3 weeks ago now, down in Georgia. And Options from Southern Oregon, Bob Hodgson from Options for Southern Oregon was kind enough to put together this presentation with me, but he's not going to be able to be here today. So I will do my best to cover his part of things, but if people have questions, I'll also take some notes and I can get those to Bob later and get answers to those. So, and if you're watching this after the fact, please feel free to email me with any questions. So, so we did a presentation at the Harris Conference about quality measures for value-based payment, and the reason we decided to talk about that was that Pinnacle has been working with Bob at Options on some data projects, and Bob's team on their own has been doing some data projects that are kind of specific to Oregon, but that might be sort of things you might want to know about because there's a lot of talk at the national level about these trends being translated out to other states. And states are at different levels in this process, but at the conference, I actually started this presentation with a little video clip from The Office. And since you can't really show copyrighted material on a video, we're not doing that today. But the point of the video was just to bring up there's a scene in The Office where Michael Scott, who's the owner of the office, is in this negotiation, and he's talking with someone who has very different goals, but they have similar like intermediate needs that they want to meet. And so the reason I shared that clip at the conference and the reason that's kind of relevant today is that when it comes to value-based payment, you know, for the longest time, we've been hearing about integration of mental health, behavioral health, and physical health. And it seems to be getting some traction now, and it's sort of for mixed reasons. So some of the traction is because individuals who are affected by mental health, behavioral health, or substance use disorder issues, the medical system has started being a little bit more interested as a system in that population because those individuals have the highest cost or have a higher cost burden to the system for their physical health needs. So it's not necessarily that mental health and behavioral health are suddenly super expensive and the insurance companies are worried about our folks because of those services being expensive. It's actually that the folks we serve in behavioral health are costing a lot of money on the physical health side of things. And this is just my impression of where we're going or how we got there. And so I think a lot of when we're talking about integration or we're talking about value-based payment, how we measure value becomes really important because the insurance companies or the physical health plans have a certain set of measures they're looking at but really the target of their interventions is to try to bring costs down on the medical side of things. And so they're interested in partnering with us to provide better behavioral health services with that end goal of trying to reduce the overall cost of care. And so I think about it as that we have similar goals or we have similar things we want, right? So the physical health plans want better behavioral health services. So that's great. It's great they want better behavioral health services. They want to invest in behavioral health. They want to understand behavioral health. But they don't exactly have the same overall goal because perhaps you could say that our goal in behavioral health is to help improve people's quality of life, improve people's independence, empower people to have, you know, more connections in their community, all of those sort of, you know, mission-driven kind of things that we care about. Whereas on the physical health side, not that they don't also have those goals around health and communities and all those things, but secondarily, they kind of have a goal around reducing the cost of care or treating people in a more efficient way and more on the physical health side because that's where they are seeing the cost be higher. So I bring that up because when you look at the measures that are kind of getting pushed out as far as value-based payment models, people are sometimes surprised because the measures themselves tend to be more physical health related, or there aren't a lot that are really specific to behavioral health. So what we end up doing to meet those measures is we're doing a lot of things that are actually a little bit kind of adjacent to what we're used to doing for behavioral health. So so that's kind of my intro to why we're thinking about value-based payment. We're also thinking about integration because the goals behind doing more funding for behavioral health sometimes are related to reducing costs on the other side, not necessarily what we would think of as the things we're designed to maximize our value, like show our value the best, if that makes sense. So, and I should have said, please jump in with questions or comments. No one's muted, so jump in if you want to add anything to that. But these are kind of the principles of value-based payment that I think about in terms of how those intersect with sort of data and reporting and electronic health records, which is, of course, our wheelhouse here at Pinnacle. So there's a shifting responsibility for managing population health. So thinking about folks that you may or may not actually have had an interaction with in the behavioral health world, but sort of thinking about them as your population. There's more accountability for measuring access and outcomes. There's this focus on integration and especially on physical health measures. And there's a focus on the outcomes and the quality of services rather than not necessarily just on productivity or the quantity of services. So it's moving away from paying you for how much service you do, moving toward paying you for what you get out of those services. And the what you get out of those services is kind of being defined right now in some areas a little bit more on the physical health side than on the behavioral health side. So in Oregon, we've been experimenting with this thing called coordinated care organizations. Bob's much better at explaining this, but basically there are these organizations, mostly nonprofit, some mixtures of profit and nonprofit, that are managing Medicaid dollars, and there's a portion of the funding that is held back, and then you can earn that money by meeting these incentive measures, so meeting certain metrics. And so, of course, these entities that are managing those dollars are very interested in meeting those metrics because it means they get this these incentive payments back. And so behavioral health comes into that because some of the measures relate to our folks, to our individuals that we serve. So let's see if I can get my slides to work. So basically, I'm going to go over some reports that we built with Bob. Some of these Bob built on his own, but using the Pinnacle Data Warehouse to address these changes. So one thing is that Bob uses a productivity report at Options, but what's different is that with value-based payment, you want to look at not just necessarily the billable services, which is traditionally what we look at with productivity, but you might want to include some non-billable services. So this report is an example where Bob has included services that are not necessarily billable services, but kind of added in the cost of those to considering kind of the full value an provider's providing. So, so any questions about this report? I'll try to kind of ask questions each one. I'll try to have my chat window open too. This also brings in, I should say, this also brings in they're bringing in their time clock or their payroll system data so that the individuals who are like out sick or on vacation, it doesn't count against them. It's their expected productivity is based on a metric that accounts for those things and based on how much FTE they are and what their expectations are for productivity. So it's a pretty fancy report. It brings in data from multiple systems. Sorry, my slides are like a little slow moving. Let's see if I can get it to move. Go slides.
Ginger, it's Michelle.
Hey, Michelle.
Hi. The detail of the report was kind of hard to see, but I'm imagining when you post it, it'll be easier to view.
Oh, is it a little too small?
Yeah.
I'm using my big monitor. I bet that's the problem. Let me see if I can zoom in. Let me try. It might let you zoom in on GoToMeeting too. Let me try going back a slide.
Oh, okay.
Oops. Let me try. Let me see if it'll let me zoom in. It might not let. Oh man, I had this figured out. There was a trick. I'm not sure I'm gonna be able to remember it. There's a trick to zoom in. Oh, it's not that. There's a trick, and I did it when we were presenting this live.
Okay, no worries.
Okay, I'm sorry. I'm trying to remember what it was.
On the top of my, this is Danny at Options, on the top of my GoToMeeting window, I've got a Zoom button that was originally 34%, and I also couldn't read the numbers, but I changed it to 100, and now I can drag and scroll the window around and see it.
Does that help a little? Sorry about that. I know there's a way I can zoom on PowerPoint. I just don't remember right now. Sean or Gary, if one of you guys want to Google that while I'm on and let me know.
Will do.
Okay, thanks. The fanciness of the Google. All right. So, okay. So, all right. So then, so population health is the other thing that that Bob has been working on at Options, and looking at a method for capturing information about clients that aren't in an EHR. So being responsible for a whole population of folks means that some of the individuals you're responsible for, say, following up after a hospitalization might not be people that you necessarily already have in your electronic health record. So Bob is working on this really cool system. Let's see. So this is the original system they were using for tracking follow-ups after hospitalization. It's a really common metric being used out there. It's an interesting metric to use. I mean, tracking whether there's follow-up after hospitalization has been demonstrated to show that people who have a follow-up after hospitalization have better outcomes. I think how you do those, I think the value of those follow-ups can vary depending on what kind of follow-up you do. Like I know I've seen some people implement this by having a follow-up appointment, but it's like as the person's walking out of the hospital, they sort of catch the person and talk to them, and that counts as a follow-up. And maybe it does provide value to that individual because it gets them engaged. It's an outpatient provider. So I think there's value to it, but it is one of those things where we both have similar, like we have a goal and there's a goal out there, and sometimes they line up and sometimes they're maybe a little bit sideways. But anyway, so Options had been using this huge manual spreadsheet. I think this is only some of the columns. You don't really need to zoom in on this, but this is, it had like 26 additional columns. It was a huge spreadsheet to track all the follow-ups, all the different factors that went into that. And what Bob's been doing here, been working on, sorry, it really only works when I click my mouse. Let's see if I can get this over here. Try this. Aha. So what Bob's been doing instead is capturing information in this is like a little program they built that builds an extra little table with information about folks who may or may not, well, it's information about folks. They add the folks to Profiler, which is their electronic health record, but they want to put some information in here about the initial crisis call, and that doesn't necessarily, they don't necessarily want to create like a service in their EHR for that because it was actually provided by the crisis services in their county, or in this particular county, are provided by an outside entity. So they record that information in here so that they can track the follow-ups out of their electronic health record without necessarily sort of like making a dummy record for that initial service that wasn't really provided by them. So this is something that's kind of cool you can do with the data warehouses. You can have sort of a standalone table that is information that's from outside of your electronic health record and then combine it with information inside. So this pulls information in, and depending on whether the person is part of their crisis program or not, they capture different information. It's a really cool little tool. That part I do not know how to make, but it's very cool. And so then their report can combine information from both places and look for follow-ups that might be missing. So and the report does some cool things, like highlights things if they didn't get a follow-up completed and things like that. All right, so then screening and outcomes. So I had some excellent feedback from my presentation at the Harris conference that I need to explain things like HEDIS measures because not everybody knows what that is. And I should have looked up what that abbreviation stands for. Does anybody know what that abbreviation stands for? HEDIS? I should know, but it's a national set of measures. So I will include that in the comments to the video, what the abbreviation stands for, and also a link. But basically, it's a national set of measures. What's really different about using those measures is that they are very specific. So Oregon is also part of the Certified Community Behavioral Health. Oh, look, Angela knows the healthcare effectiveness data. Oh, I missed it. Where'd it go?
An information set.
Thank you. So good. Smart people. You guys are awesome. Thanks, Angela. Healthcare effectiveness data and information set. Awesome. So these measures are just extremely detailed. So down to the level of some of these measures only include certain diagnosis codes, only include certain CPT codes, only certain payers, only certain credentials, very date specific. And when we first started having to track these in Oregon as part of the Certified Community Behavioral Health Center demonstration project, I was actually part of the committee that went through these like line by line and tried to actually interpret them. And it was just a whole nother way of thinking about data because, in behavioral health, I've gone to multiple meetings, for example, back before our current setup, we were always supposed to be tracking access measures, for example. Well, we could never really define what we meant by access, what counted as a first contact, what counted as your next contact, did you have to have an assessment, what counted as 14 days, did it include weekdays, did it include holidays? Well, all of these things that we never could quite agree on, we always went back and forth and different places tracked it differently. Basically, these HEDIS measures sort of try to eliminate all of the room for ambiguity. So they're super detailed, and that just means that writing the reports for these measures is also really complicated and detailed. So it's a whole nother way of thinking about things, and if you've been doing meaningful use, you might have used some of these measures, and so you might be familiar with it, but a lot of the vendors, the way they're adopting meaningful use measures is they're just dictating because they can't handle writing these reports 20 different ways. So they just say, if you're doing this measure, use this cross-reference. If you're doing this, do this. If you're doing this, do this. And it's a way to kind of get around all this complexity. But if, like we have in Oregon, we like to give people a lot of flexibility to do things different ways, it means you have to write these really detailed reports that meet all of these criteria. So and besides just measuring these reports afterward, you want to track how you're doing on these because you're being measured on how well you're doing with performing these. So, so Bob has been, sorry, I have to keep remembering to click in the right place. Let's try this. Okay. So this is just an example of one way that you could, we've talked about this caseload report before with Pinnacle, but this is a caseload report that brings in data from is looking at some different rules of deadlines people need to meet for different things. This is for more of the traditional, like when someone's assessment's due for review, when their treatment plan's due for review. So the last column on here, it kind of relates more to outcome measures. That's measuring the last DLA 20 score. But something like this is kind of an example of how you could organize information so that your clinicians could see what's coming due for other types of measures. Like some outcome measures are really just measures of how often you do a screening and follow-up for certain criteria like tobacco use or alcohol use. So this is the kind of format you could use to keep track of so that a clinician could look at a report and figure out who met the criteria for different screenings and whether they've had them. Okay, just a sec. Here's another example. This is for the PHQ-9. So one measure that is being used by the Certified Community Behavioral Health Centers in Oregon is a measure around depression remission follow-up or depression remission. So it's very specific. So it goes by did you have a certain score or higher on a PHQ-9 on a given day? And then 12 months later, plus or minus 30 days, did you have a score that met the criteria for being in remission? And so that's a really hard thing to keep track of if you're a clinician, right? You've got enough things to keep track of. So we're trying to make some reports to make it easier to know, who's coming due for these follow-ups, because it could be someone who's now been closed out of services, right? It's been a whole year. Someone may have left services. That may or may not mean that they're in remission, and wanting to capture the data for those folks to see how they're doing, which is kind of a cool thing we're doing. It's also kind of counterintuitive to what we're used to doing, right? So calling someone up and doing a PHQ-9 over the phone to see if they're doing better, that's not a bad thing, but it's also just something different than what we do in our normal business. And then this is a similar thing with alcohol use screening. So this one, you have to have an alcohol screening at least every year if you've had 2 or more services. And so again, this one, we made it a little simpler to say, okay, what's the next appointment that's coming up for someone and who's it with, and could we get that alcohol screening done during that appointment? So the other thing that comes up with like value-based payment and integrated care are these things called care registries, or where you do some risk stratification. So identifying the factors that would make someone be at higher risk of some kind of negative outcome, and then using data to find opportunities to implement some evidence-based practices. So this is one example of some risk stratification that Bob's been doing. Looking at folks who, like just looking at a whole bunch of criteria about individuals who have maybe had some kind of crisis event. Did they have a follow-up? Did they have a service? You know, how long after the service? Where was their service provided? Just a whole bunch of data. And you know, these kinds of reports, you know, the direction the field is moving is that you would have something like this, and then you would sort it down to find certain pockets of populations that had similar characteristics, and then apply certain like evidence-based practices to those folks. So you would maybe have a nurse who would have a list of everybody who met the criteria for being at risk of diabetes, and then have that person call up people who maybe recently started a med that had a potential side effect related to metabolic syndrome, and make sure that they got labs done. That would be an example of like a care registry. This is just an example of a report that Bob's using around early child services. So just thinking more about taking on the role of looking for people who might need a certain type of service. So if you kind of think of like your population of individuals in your community, and then who might need these services. So it's a little different than how we maybe traditionally think of services, where people kind of self-select. Like, you know, we might mention, hey, we got a new group coming. Who wants to be a part of the group? Whereas this would be more like, perhaps, you know, looking at what are some common things going on with the folks that we're serving, and could we start a group around that? And if so, let's call everybody who meet that criteria and see if they want to be part of the group. I think that might be my last slide. Yes. So what questions or comments do people have about that? Wow, if I take away my screen share, you're going to see me really big. Hi.
So what sort of, has this saved a lot of time over at Options? What could the people from Options tell us about how that's improved their process?
I'm just involved in creating the reports. I don't know, I don't have any firsthand data from time saving yet.
Have you had any comments? Oh, any comments from users or anything?
Doesn't everybody love cool new reports?
Yes.
Love that. That's great.
Yeah, sorry, I don't have much more for you there.
Oh, that's okay.
The productivity report has been out for quite a while, and they definitely like that and use it.
For sure. And Angela from CCMH, you might recognize some of those reports too. We showed a couple that we used for you guys as well. Do you guys find those useful?
I think the director level likes to see that information. I don't know how much the counselors are really in tune to that level yet. But I think at the director level, I think they find it interesting to see like have a different aspect of actually doing like the follow-up with depression remission. So we actually have like those cold calls, so to speak, to clients that are no longer engaged in services, but we still reach out to do that 1-year follow-up. So it's a very different approach to behavioral health. And we're having our medical assistants do that actually, who's doing those calls currently. Otherwise, a lot of the staff just think they're annoying, all the different metrics. The one thing that we have found incredible that people are liking is we were able to create the PHQ-9 as a graphical representation on the individual client's chart. And so that suddenly made them think the PHQ-9 wasn't as bad, because they could actually use it visually with a client and say, oh, look, see, I see you're trending up, or I see you're trending down, you know, and they're using it. And I've got a lot of excitement from staff that they're able to use it hands-on, and it's real data right there on their screen. So I thought that was kind of exciting that they actually did like something and actually were not just annoyed with another screening. So now they want the GAD-7 the same way, and they want to start thinking about other metric tools that we can utilize that would also be engaging for the client to see improvement and outcomes.
That's awesome. That's a super good use. That's really helpful to know. So kind of having the visual marker, like it made more sense to people once they could see changes over time, and then they could engage individuals they're serving with that data a little bit.
Yeah, and it's just on their home screen, so it's really, and it just was the last the last 2 or 3 scores, so it doesn't have a really large graphical representation, but it kind of gives them a snapshot of in time of if somebody's going up and down or what's going on with that. And so they said they're actually like turning their screen and actually like showing the clients, and I was like, that's super exciting, like collaborative documentation. So cool.
Yeah, I love that. That's awesome. Very cool.
Yeah. So now we just got to figure out other ways to get them that excited about other things.
Right. Yeah, it kind of comes back to that thing where, you know, it's a little bit of a stretch if you're used to thinking about sort of like the mission of behavioral health, and then these metrics don't necessarily feel like they fit exactly into what we're really good at doing. You know, like it's not measuring like, you know, you did 5 outreach attempts and you finally got someone to come in and see the prescriber. They didn't start their meds, but they at least saw the prescriber, and maybe next time they'll start, you know, they'll be open to maybe taking some medication to help with, you know, hearing voices or something like that. Like, I mean, things like that are the things I think behavioral, particularly community behavioral health, is really good at. And sadly, these measures, I mean, some of these measures would just say, yeah, but did you do an alcohol screening? And if you didn't do an alcohol screening, then it doesn't count.
Right, and that's where we're really developing like our peer services, and so we created a lot of forms for the peers to be able to document on a client that won't tell you their name or something like that, like you just know them as man under the bridge. And that's what you know the person as, and they've done outreach with them, just so that we can track the amount of outreach that we're doing and see if we can actually see an increase in number of people served, or if we can eventually like show what those peer outreach services are doing, even for clients that aren't willing to give us information to be our client, so to speak. So, of course, they feel a little overwhelmed with the amount of forms and data points that I'm trying to get them to collect, but I'm trying to teach them that it's like, well, the reason why we're doing this is so that we can show later what work you're doing that is not a normal billable service that I can't put in a billable category, but it's still great work that you're doing.
Yeah.
So.
Yeah. In like a really idealized version of value-based payment, that we should be able to, if we can demonstrate the value of those services, we should be able to receive payment for that, regardless of whether it's billable or not. I mean, theoretically, that's how value-based payment is supposed to work. It's supposed to be based on like, hey, you know, overall, the population of folks in your county are doing better. Whatever it is you're doing is working. Here's some money. But it doesn't always seem to translate to that. So,
yeah, we're really hopeful that like because they're going to be like also doing all of our hospitals, so using now I totally forgot the name of it, where you get all your hospital information.
Eddie pre-managed.
About hospitals. Yeah, pre-managed, using that information and doing follow-ups and doing those cold call type follow-up things, and using our peers to do those things and just reach out and be like, hey, did you know? Like, do you know about our services? We're here. And like, if they want to like, oh yeah, it was nice that you reached out. Like, okay, well, maybe we go and talk again, and like eventually maybe get somebody into treatment that maybe in the past they would have gone to the back and forth to the hospital and nobody would have done anything with them. And so we're hoping that we'll have that peer approach that's not so clinical, because I think it's less intimidating sometimes to people that aren't sure if they want to go to therapy and counseling and that thing. But if it's a peer reaching out, it's a little less intimidating.
Yeah, for sure. That's a great use of peers, I think. It's a great use of that service. For sure. Yeah, there's an interesting article, I think it's in Time magazine or something, that just came out yesterday or today, that's about suicide prevention and about how important following up after a crisis can be, and how agencies that are implementing more of that are seeing really great outcomes as far as like reducing their suicide rate. So I think that's really valuable. I think that's really important. I think the more that we can have that outreach be a person-to-person connection versus I'm not sure that I would agree that it's necessarily as effective to have like someone get 10 text messages from an automated bot that says, how are you doing today? I mean, that might help some people. There might be some benefit to that, but I'm a big, like, meaningful human connection as sort of the marker.
I really, so far from what the peers have reported, which we've only really had the peers doing this for maybe 6 weeks.
Oh, did we lose you, Angela? So far?
Yeah. Oh, there we go. So far, my phone is going in and out. So far, they've already said that they've had several clients that in the past, like maybe they had been clients with us in the past and they weren't really sure if they want to come back or whatever. And so we've been able to get more clients. And I think within the last 6 weeks, I think they said they had at least 10 clients that they could remember offhand that they had gotten at least in the first appointment. Now, whether or not anything happens after that, but that's something that I told them with them recording the services the way they are, that hopefully eventually once there's enough data there that we can start trending that information and see that all these outreaches and of the percentage of clients that you did outreach on, this is, increased our assessments by this amount and increased our actual, clients utilizing treatment by this amount, so that hopefully we can start to trend some of that data.
Yeah. And then probably to really engage the physical health side, if you said, and hospitalizations went down by this amount, sadly, but they will be interested in that as well.
Yes.
Yes.
Of course.
No, that's great. Does anyone else have any questions or comments about anything there?
Ginger, I just wanted to ask if you could go back to that other slide now that I know how to work my screen.
Oh, sure. Yeah.
Because I felt like that was really valuable information that you shared with us, just in knowing how to track the non-billables.
Ah, yes.
Because that's what, and the non-billables help us get to the billables. So we really want to be able to now I'm going to concentrate on how to do this for a second. Really want to be able to do that.
I might be able to zoom it in. Let me see if this will work. I don't know if this will work.
I figured it out. I just
did that help?
That's helpful, but the Zoom feature really does make a difference. So there we go. Thank you.
Sure. Yeah, and I think at Options they have certain services that sort of count as their sort of productive non-billable time versus like not necessarily counting all their non-productive non-billable time as productive, but they have certain like there's basically 3 buckets, right? There's like productive and billable, there's productive and maybe not billable, and then there's like doesn't count in productivity or billable, which would be more like, left a message for someone. Although I would argue even some of that stuff we probably should keep track of because that's the cost of doing services and it could be adding to our value, right?
That's right.
There might be still some things that wouldn't count for either thing. I'm trying to think of what that would be. Do you happen to know that side of things very well, Danny?
I don't have a specific example, but what you're saying makes sense to me.
I love it. Thank you. Good positive feedback. Yeah. Does anyone else have any questions or comments?
I would add one note on the caseload report that you showed a little earlier. When you showed DLA 20 scores, we almost have that out, and it's been used for over a year now by managers, and we have a version that's for each logged in provider so they can see their own. Mm-hmm. And when somebody saw that, they said, could I have an indicator by that DLA 20 to tell me when it's coming due?
Oh,
and so
okay.
We've added that. So you're looking for testimonials of people using it. And as soon as the individual providers saw that report, that's what they wanted added.
Nice. That's really positive. Here, maybe I'll pop to that report real quick here. See if I can get that. Yeah, so you're saying they were like, oh, I like these little indicators next to the other things. Get me an indicator over there. Here, I'll zoom it.
Yep.
Now that I know how to zoom in, maybe.
So we try and do that every 90 days. And
nice.
So there's an indicator yellow after 60 days, and then it goes red after 90 days.
That's awesome. Yeah. Any other questions or comments? All right, you guys. Well, have a good rest of your Friday, and we will talk to you again soon. Thank you so much.